Welcome to my channel. From today onwards, we are going to begin our medicine cardiology series. In this series, we will cover important cardiology concepts in a simple, systematic, and exam oriented way. I hope this series will help you understand the concepts better and make your MBBS easier. Stay till the end of each video, and I am sure you will take away something valuable from it. Today, our topic of discussion is aortic stenosis. But before that, let us have a brief discussion on normal anatomy of aortic wall. Location of aortic wall. It is present between the left ventricle and aorta. The exact position of aortic wall is at root of aorta. You can also see in the image, aortic wall is made up of connective tissue ring called annulus, which is having three cups or leaflets. The annulus will help the leaflets to hold on to the wall of aorta. And the function of the aortic wall was to prevent the backflow of blood from aorta to the left ventricle. Coming to the normal orifice size, that is 3 to 4 centimeters square. If it is less than 2.6 centimeters square, then we call it as aortic stenosis. Now let's go deep into the topic. The definition of the aortic stenosis is the narrowing of the aortic wall resulting in obstruction of blood flow from the left ventricle to the ascending aorta during systole. The causes of the aortic stenosis. In case of infants, children and adolescents, the first cause and the most common cause is congenital aortic stenosis. Normally, the aortic valve will have three leaflets as we discussed before. But some individuals are born with an aortic valve that has two leaflets. The most common mutation responsible for the congenital aortic stenosis is Notch1. And the second cause is congenital subvalvular aortic stenosis, that is below the aortic wall. The defect is in the below the aortic wall. And third one, congenital supravalvular aortic stenosis, that is above the wall. Coming to the young to middle-aged adults, calcification and fibrosis of congenitally bicuspid aortic wall. Second one is rheumatic aortic stenosis. Middle-aged to older adults, the first cause is senile degenerative aortic stenosis. Here, it starts with atherosclerosis, then it becomes calcification, later it leads to the aortic stenosis. And the second one is calcification of bicuspid wall, and the third one is rheumatic aortic stenosis. Coming to the pathophysiology, whenever there is a aortic stenosis, there will be the decreased stroke volume. What do you mean by the stroke volume? The amount of blood ejected by left ventricle to aorta in one systolic contraction is known as stroke volume. Whenever there is a smaller the opening of the aortic wall, then there will be decreased in the stroke volume that leads to the fatigue and the syncope. And also here we need to know two things, that is preload and afterload. The preload is nothing but the end diastolic volume. When we call it as a preload means like when the workload on the left ventricle increases, we call it as a preload. And afterload is the resistance by aorta and its branches for ejection of blood by left ventricle is known as afterload. Here in aortic stenosis, the afterload gets increased. Whenever there is an increase in the afterload, you will see a concentric left ventricular hypertrophy. Again, here we need to know two important things. In hypertrophy, there will be two types of hypertrophy. The first one is concentric hypertrophy and another one is eccentric hypertrophy. When we are having a increase in the afterload, then we will see the concentric hypertrophy, which means the muscle mass gets added inside the ventricle. The outside thickness will be the normal, but inside thickness gets increased in case of increased afterload. But in case of increased preload, there will be eccentric hypertrophy where the mass gets added outside to increase the size. I will also add the image, just have a look on it. The thing that you have to remember here is the concentric hypertrophy occurs when there is increase in afterload. Eccentric hypertrophy occurs when there is preload. So when there is increase in afterload, that leads to the concentric left ventricular hypertrophy, that leads to the increase in a myocardial oxygen demand. So the decrease in the stroke volume is going to also lead to the decrease in the coronary flow. This decreased in the coronary flow and the increased in the myocardial oxygen demand will lead to the demand supply mismatch, which is leading to the ischemia and causing angina. So coming to the symptoms, the earliest symptom will be the angina, afterwards syncope, then dyspnea. Coming to the next point, on examination, we look over three things like blood pressure, pulse and the apex beat. The blood pressure will be normal. I think majority of the people have a question mark here. Like the systolic blood pressure will be directly proportional to the stroke volume, then why we don't have a hypotension at all the time at presentation? Because because of the compensatory mechanism of the RAS, there will not be the hypotension, so the blood pressure will be the normal. To majority of the cases, it will be the normal. In some people, in some persons, it will be relatively low. So that's the reason behind this. Coming to the pulse, what do you mean by the pulse? The pressure wave that travels through the aorta and its branches is called pulse. Here, in case of mild to moderate aortic stenosis, you have a anarchotic pulse or pulsus parvus. What do you mean by the parvus? Means small. You will have a small amplitude pulse. In case of severe aortic stenosis, you will have a small amplitude and late peak appearance, which is called as pulsus parvus et tardus. Tardus means slow. Coming to the apex beat, what do you mean by the apex beat? It is the only part of cardiac contraction that can be felt externally. The conditions where we will have a displaced apex beat is only in a conditions where there will be the dilatation of the ventricles, or where it where there is a eccentric hypertrophy, then we will have the displaced apex beat. But here, in case of the aortic stenosis, the apex beat is undisplaced. We have a undisplaced apex beat. Coming to the auscultation finding, here in aortic stenosis, we will have a ejection systolic murmur, which is also called as crescendo, decrescendo murmur. Now, as we go, you will know why we call it as a crescendo and decrescendo murmur. Generally, in a normal valve, only in a closing time, in a closure, there will be a sound. But in an opening, it doesn't make any sound. As all of us know, S1 is produced by mitral and tricuspid valve closure, which is the beginning of the ventricle systole, and S2 because of the aortic and the pulmonary valve closure, which is the beginning of the ventricle diastole. We know that systole means ejects the blood from the left ventricle, and diastole is the filling the left ventricle with blood. So as we already know that aortic stenosis is the something that is defect in the systole of the cardiac cycle, so that we are having a systolic murmur. So there is a phase of cardiac cycle where ventricle is contracting to open the aortic wall, which is called as isovolumetric contraction. This contraction will create a pressure which is enough to open the aortic wall. so which is making a sound. So the thing here is, then in a S1 to S2, there will be a first there will be isovolumetric contraction, then there will be a click or a ejection click, which means again in a ejection we are having a two phases, that is a rapid and a slow or a delayed. In a rapid ejection, the movement of blood from left ventricle to aorta is in increasing velocity. Whenever there is a increased in velocity, the turbulence also gets increased. Whenever the turbulence get increased, there will be the the intensity of the murmur also gets increased. But in case of the slow or a delayed ejection, the velocity gets decreased. Because of the decreased velocity, the turbulence also gets decreased and the intensity of the murmur also decreases. That's why here in a ejection systolic murmur, the intensity of the murmur does not remains the same. That's why we call it as a crescendo and decrescendo murmur. Now, it is best heard in right second intercostal space. We have to remember here the right side murmurs are more heard in inspiration and left side murmurs are more heard in expiration. And the murmurs are more clear in case of aortic and pulmonary wall is sitting and leaning forward position. That is important and we have to remember it also. You can also see in the image B, there is a crescendo and decrescendo murmur in case of aortic stenosis. Now moving further, let us discuss about what are all investigations. The first one is echo, which is the investigation of choice. We can also call as 2D echo. Here, we will notice the calcified valve with restricted opening, hypertrophied left ventricle. And the thing we have to know here is, if the aortic valve is less than 2.6 centimeter square, it is called aortic stenosis. If it is less than 1 centimeter square, it is called as severe aortic stenosis. In case of ECG, we will have a left ventricle hypertrophy is noticed. Coming to the management, the definitive treatment will be the aortic valve replacement. But in case of patients who are unfit for surgery, then we will do a transcatheter aortic valve implantation. But here we have to know this, we have to avoid the beta blockers and the diuretics since they are reducing the stroke volume. If the stroke volume is reduced, as we know, it leads to the fatigue and syncope and also decreased coronary flow, and that will again leads to the ischemia and angina. So we should avoid the beta blockers and diuretics. Thank you for watching this video till the end. I hope you found it useful. In my next video, we will be discussing an important cardiac condition called mitral stenosis. So stay tuned and I will see you in the next video.